Going to go ahead and call this meeting to order. Basically what we're doing, this is more of an information situation than anything else. The presentation has already been done, I think maybe twice, once with Mr. Fontaine, and then Mona gave the same presentation to those who were there for a second one. And this is going to be the third culminating one. We had some questions about some things and whatnot. So right now what we'll do is we'll turn it over to Mr. Fontaine. He'll make the presentation on some items to save the plan some money. And we'll go through that. And there's some things we will be able to do, and there's quite a few things we're just only getting information. So we may not vote on it tonight. We're just going to basically have the information on it. So, yes, ma'am. I think we can do it. Okay, we can. Okay, looking at the agenda, do I have a vote for approving the agenda? I'll say aye. Okay, it's moved and seconded. All say aye.
Aye.
Any opposed? The agenda is approved.
We have a quorum.
We have a quorum. Okay. We have some representations, from maintenance and the trades that are not here, and of course we do have one of the representatives from the LPAE is working, so that's just where it's at. So we'll start off with Mr. Fontaine and the presentation to save us some money for our coming year.
All right, first thing on your agenda here is you had an update on Blue Cross Blue Shield, Louisiana's Medicare Advantage program. So here's a comparison, and I'll explain that to you.
Thank you.
Can you speak on a mic?
Do you have some for the people who are here?
We're trying to get them on the. Do we have a copy of it? Do we have an electronic copy of it?
This is Medicare.
Can you keep one in case somebody comes late? Because the last time I didn't have an opportunity to get one because they were all passed down.
3.
So if you look at the comparison before you.
Man, would you wait 1 second? He's going to put that on the screen so everyone can see what you're saying. What you're talking about.
I put one here.
He's on.
Everybody. Hello?
I can make more copies.
Projector heat the place up.
Oh, yeah.
Okay. Can everybody hear me? All right, so when you're looking, what you have before you is your current plan with Humana, the renewal plan, which has no changes to it from a benefit perspective. I'm pleased to tell you also, from a rate perspective, there's no increase in rates this year from Humana. Blue Cross's plan, the benefits, and I'll start at the top here. Your current plan is basically a passive PPO plan, which means that you can go to any provider that accepts Medicare and will file their claims to Humana. And that provides for a very broad choice of providers. The Blue Cross plan utilizes an HMO network, which is going to have in-network providers in certain areas of the state and an out-of-network benefit. So if you go out of network, you're going to, you see here, just from an inpatient hospital standpoint, you would pay 15% of those charges until you reach your maximum out-of-pocket, which is $1,000. You see that down at the bottom. Going down the list here, your current plan requires no copayment, no deductible for any of your medical services from inpatient hospital all the way down to emergency room. You do not pay a copayment when you utilize a physician's office visit, urgent care, ER, any of those types of things. So there's no deductible. There's no co-payments. The only co-payments involved in your current plan with Humana is with regard to prescription drugs, and you see the co-pay structure there down at the bottom. 10 for Tier 1, which is going to be your generics or low-cost drugs, $30 for your formulary, preferred brand name, and so forth there. Your maximum out-of-pocket on your prescription drugs under the Humana plan is $2,500. After that, 100%. With the Blue Cross plan, if you, once again, if you go out of network, any of those services are 15% until you hit your maximum out-of-pocket of $1,000. On in-network benefits, there's a $10 copayment for a physician office visit for primary care, specialist $20, urgent care $20, and also $20 for any type of therapy, whether it be physical therapy, occupational, or speech therapy. So there is some difference not only in benefit structure, but I would say a significant difference from a network structure. Blue Cross, in conversation with them, is developing this HMO product first, and we'll have a PPO product for looking at an effective date of 1/1/19. So the only products that they are going to be offering on a group Medicare Advantage basis will be this HMO product offering. This is a bit different from what they first had proposed to us, but this is where they are right now, and all of this has been clarified and confirmed. From a prescription drug standpoint, a bit of a different benefit. You know that you have your current 10, 30, 60, and 10% with a $2,500 out-of-pocket. Blue Cross is out-of-pocket, also $2,500, but has a higher copay structure at 15, 40, 70, and 10%. That 15, 40, 70, and 10% is your copay structure until $4,950 of claims have been paid. After that, it reverts to the $3.30 for or 5%, or the $8.25 or 5%, and that 5% goes towards your maximum out of pocket. So a different copay structure on the prescription drugs as well. Any questions on the benefit comparison? Yes, Butch.
I think we need to make that distinction between PPO and HMO to make so that everybody is understanding what this HMO situation is going to be, because when we had talked, they were going to do the PPO.
Right.
So that has completely changed.
That has completely changed. So it is a HMO stands for Health Maintenance Organization. It is more of a restrictive network. That's why it is does utilize the out-of-network benefit. But you, in comparison to your current plan, you basically do not have an in-network or out-of-network benefit. You basically can go to any physician or any provider that accepts Medicare and is willing to file a claim to Humana. With Blue Cross, you have to utilize to have that in-network benefit, you have to utilize a more restrictive list. Now, remember, on your partially self-funded traditional plan, where many of the Medicare-eligible retirees are still participating, okay, you have a PPO network, much broader choice, okay? as these networks develop, as these products develop, we'll keep you posted. But presently, this is Blue Cross's 1118 Medicare, Group Medicare Advantage offering from a benefit perspective. Okay?
So you're saying that if we go to this advantage, we now run the risk of losing all the doctors we have, then we'll have to go to brand new providers. Because if they're not in the HMO list, you'd have to select a new doctor according to that.
You could.
And that's an advantage
You're
for
not,
me?
no ma'am, it is a disadvantage.
Yes, it is.
Okay?
I agree. It's a
So
disadvantage.
if you're comparing your current Humana plan with a, basically, they call it a PPO plan, but it's basically you go to any doctor who accepts Medicare and is willing to file that claim with Humana. So obviously, very broad choice. When you go to an HMO network, more restricted choice of doctors, hospitals, or medical providers. So that would not be an advantage, that would be a distinct disadvantage.
You work with St. Tammany and St.
Yes, ma'am.
They have this advantage plan.
No, ma'am.
Just to clarify, this is only for the Medicare Advantage plan. It's not for the regular. Okay. I'm not sure if they're in the audience. Right.
So she asked, I represent other school systems in the state, and she had specifically asked about St. Tammany. St. Tammany does utilize Blue Cross for their traditional partially self-funded plan. They utilize Humana for their group Medicare Advantage. They utilize a PPO plan for those that are living in the state. They, HMO plan for those that are living in the state, and they use a PPO plan for those that are living outside of the state. Correct, Aaron?
So this is not what you originally thought you brought?
It's not what was originally presented to me. Okay? There wasn't a thought process to it. I'm presenting to you what was originally given to me, and it's
Not recommending this, correct? I know we're not voting tonight, but just so we can put some people's minds at ease who think they might lose Savannah, you're not recommending this.
I would not be at this particular time, because if we are talking about a population of 207 out of your Medicare eligible retirees, I could not see that this would, anybody would be attracted to a lower set of benefits and a lower choice of providers. Especially given the fact that the premium for a retiree is zero. You would have to have a negative premium for this to be any advantage to you.
Okay, we have a question in the audience.
Yes, ma'am. Mm-hmm.
And the doctors stopped taking. Everybody we went to and signs no longer taking Humana. And now, our doctors, Blue Shield. Now we're seeing signs no longer take HMOs.
Oh, wow.
We just had
This is
surgery.
interesting.
$34,000 eye surgery.
Mm-hmm.
Oh, okay. The surgery was $34,000. Didn't spend a night in the hospital. Humana and Blue Cross, not Humana, I'm sorry, I'm nervous. Medicare and Blue Cross Blue Shield paid everything. This doctor has a sign on his door, no HMOs. So we're gonna have to change doctors.
No, ma'am.
No, you're on a PPO.
You're on a PPO plan. Okay.
How can I make sure that that's not recommended?
Okay, there's several ways to make sure. You can always check your providers by phone, by email, by talking to your doctor's office. But the Blue Cross PPO network is probably one of the largest networks in the state. It's hard to find a doctor, a hospital, or medical provider that doesn't participate in Blue Cross's PPO network. And the
Right.
HMO network, as just explained, is a more of a restrictive network.
Right.
Not heavily, but it is more restrictive, okay?
Supplement.
Yes,
They have-
yes, thank you, Doctor.
The HMO that's proposed.
Wait, you gotta have the mic. Okay, Daphne.
Many people here are confusing the Blue Cross supplement that they have now with this. This has nothing to do with the Blue Cross supplement that you are on. So please ignore this unless you're on Humana. This has nothing to do with you, and would you please make that clear?
That's a great way to simplify this discussion today. If you are not participating in the Medicare Advantage plan with Humana, this conversation is not applicable to you.
Mr. Fontaine, I just out of over here, I'm sorry. Just out of curiosity, did Blue Cross Blue Shield withdraw their original offer and come back with this? Or I just,
Well, this is brand-new product area to them. So they are working with their actuaries, and yes, they have made some changes from original proposal. Yes, ma'am.
okay.
Any other questions?
Wait, who?
I just wanted to say, this is so confusing to some people, because if you weren't at that last meeting, because the second, Blue Cross is a secondary plan to Medicare, right? The
So
way we
if
have
you
it now.
participate in the traditional partially self-funded plan,
Right.
and you are Medicare eligible, and you've taken your Part A and Part B, Medicare is going to be primary,
Right.
and the plan is secondary, which acts like a supplement.
And so that's not going to change.
It's not changing.
That's not going to change. So you can probably clear the room of a lot of people.
As I mentioned, there are only 207 of the retiree population that's participating in the Humana plan. I will tell you this, it does deserve some consideration, okay? And it deserves a lot of consideration. In speaking to...
Maybe you want to catch them up for the people that weren't here, how we got here. I think there's some disconnection as to why we're even looking at this, because currently we have the option of you staying on the plan with Medicare with the self-funded plan as your backup, or staying on Medicare with Humana as your backup, which is what you have, right? So you have two choices. And what we're talking about is changing the choice of Humana to a Blue Cross product. And originally that Blue Cross product was going to mirror Humana.
It was a PPO.
And now we're hearing it's not mirroring Humana. So this has nothing to do with the other plan, but the option that we were looking at, changing Humana to Blue Cross, because we had heard that it would be much more popular if it had a Blue Cross label on it rather than a Humana label on it. So now we're just, part two, looking at the choice between Humana as a Medicare supplement or Blue Cross as a Medicare supplement. Obviously, the Blue Cross option they've come with us today is just not a good option. So we need to stay with Humana, but the Humana option is still there. Right. Okay, so just in case people that weren't here, how we got to where we are today, that's where we come from.
So the majority of the retirees participate in the Blue Cross PPO plan, of which Medicare is primary, and you basically are utilizing the Blue Cross plan as your secondary coverage and your prescription drug coverage, okay? That's as simple as I can tell you on that. And you have that choice. Now, there are only 207 retirees participating in Humana. But what I am saying is I urge everyone to do your homework, because you're talking about a pretty big difference. Some of the things in the homework you want to consider. Do not be confused. Sometimes in a doctor's office it might say, we do not accept Humana Gold or something along those lines. Those are individual Humana products, okay? This is Humana's group Medicare plan, which has very, very broad provider choice, okay? So you want to make certain that one of the first things, or probably the predominant thing you look at when you're looking at a medical plan, is choice of doctors and hospitals, okay? So you want to make certain that your information is correct, because if a doctor is not accepting a certain insurance company's individual product, does not necessarily mean that they don't accept the group product. So make certain that that's correct. Secondly, under your Blue Cross plan, there's premium. For example, a single retiree that's Medicare eligible or Medicare primary has a monthly cost of $90, okay? And on the Humana plan, there is no cost, okay? So that's basically a little over $1,000 a year of savings. In addition to that, Medicare Advantage plans have a lot of value-added benefits. Silver sneakers, things like this. That adds up, okay? That can be very valuable, especially when you consider some of the vision benefit embedded in these plans, some of the dental benefit embedded in these plans. So from a benefit perspective, your current plan, if you're participating in the Blue Cross PPO, which is basically Medicare, and then utilizing the Blue Cross plan as secondary coverage and utilizing the prescription drug benefit, you have a super rich plan with very little to no out-of-pocket costs, just like you experienced in that eye surgery, okay? Well, the benefits across this page here under the Humana plan are 0 copays, 0 deductibles, all down the line. Okay? So what's the biggest question? Okay? Are you comfortable with the medical providers in the Humana plan? So really you need to do your homework, because I think there was some not misinformation, but confusion more than anything else. Don't be confused if they're not taking an individual product. Look at the choice in the Humana plan and weigh the difference of premium out. That's why you have an employer who's gone to the lengths of offering you choice. What meets your needs, okay? But the Humana plan does deserve a look. It does deserve, you know, if I've got a little over $1,000 on the table, and my physician and my hospital and my diagnostic providers are in network, I'm going to give it strong consideration, because, you know, your retirees are on fixed budgets and fixed income, and $1,000 is a lot of money. Okay? So it deserves due consideration, really does. Okay? Yes, ma'am.
I know we're asked, is there a place to go and find out who the Humana providers locally are?
Aaron, you want to address that?
Oh, wait, microphone.
I got it.
The question is there somewhere they can go to find out what providers are on the plan? And this is Erin Day, and she
Miss
is
Erin
with
Day,
Humana.
she's with Humana.
Hi, everybody. I wish you could, have an easy go to our website and see if the provider is on the plan, but because this plan is what we call a passive PPO network, that means you don't have to be confined to the providers in our network. As long as that doctor is willing to accept Medicare and send the bill to Humana, then you can see that doctor. So per se, on this plan that we're offering to you, it is not a network plan. The two things you need to ask the provider that you're wanting to see is, do you accept Medicare, and will you send the bill to Humana? And if the answer is yes to both of those, then you can see that doctor, and the benefit is going to be the 100% coverage benefit that is on the sheet that you see tonight.
So, pretty broad choice. One thing I want you to remember here, if you're in the blue plan, okay, Medicare primary, blue plan secondary, and utilizing prescription drugs, remember that if you're Medicare eligible and you're seeing a physician, he's already answered question 1 for you. He accepts Medicare, okay? So you're halfway there, all right? I'm not saying one plan's better than the other. What I am telling you, they're very, very like in benefits. One has no cost, the other one has cost. One has a specific list of providers in a network that you can look up. The other one you might have to do a little homework on and make sure that your providers are in network. But there's some money on the table. So it's to your benefit to study this and make sure that you choose with the proper information. All right. Anything else on the Medicare Advantage comparison?
Maybe I can ask, would the retirees, and most of you here are retirees, would y'all like to set up a meeting where we can have the representative from Humana and they can be here to give you the information that and a question and answer series for your particular circumstances? We can perhaps do that. We were going to set one up with Blue Cross Blue Shield because when, like Matt said, when we came in, I had no idea that it had changed. When I looked at that, I said, that's got to be an error. It was the PPO. When we had, when Mr. Fontaine and I had talked and we had seen the paperwork and whatnot, it was a PPO situation. This changes it completely, absolutely completely. So we'll have to decide whether we want to bring them in, whether it's going to be worth it or not, because we had already kind of, from the feelings that we had picked up, HMOs were not something that the retirees wanted because they may have to change their doctors. Now, if you didn't want to, then you could get the out-of-network cost, which is going to be a pretty significant increase in your cost. So, I mean, we can do what you want. We can actually call a meeting for you and then invite Humana to come in and give the sales pitch. Would you like to do that? Say yes or no. Raise your hands if you would like to have a meeting. Okay. All right. Well, we'll do a little survey and see if it's worth it or not. Yes, ma'am.
But Bush, didn't you tell us that Humana, the office that's over there by the Albertsons, at the corner of Ambassador Caffrey and Collie Slou's, don't they have a once a month meeting that's open? I mean, you may not have to call a meeting here.
Yeah.
And you could go in at your convenience, just that once a month time.
I'm sorry, I did forget about that. Yes, ma'am, I told you. Yes, absolutely.
Second Tuesday of every month at 3 p.m. at the Humana office by Albert.
Give them the address again, please.
4422 Ambassador Caffrey Parkway.
Right by Albertsons.
By Albertsons. Between Albertsons and Kohl's.
Oh, okay.
3.
Okay, the problem is solved. All right.
And I think on the last meeting, for those people that weren't here also, Ms. Villamaret stood up and gave a testimonial for some of the benefits that were here that I had not heard of and was quite surprised about some of the things that she was getting through this plan that she's not going to get with the Blue Cross plan. And that was good to hear because I hadn't heard such a good person that's been on it for a long time that was actually worried about being kicked off of it and started going through all the benefits, and I was just surprised at that.
Okay, any questions? We'll move on to, yes, ma'am.
But I think maybe if you want,
okay. If we want to let everybody know what Humana is, because a lot of people have no clue about what it is. If we had scheduled one meeting here, we can send out a letter to all the retirees, at least in the organization I have, and tell them about it and have them come learn, because some people may want to change once they learn, but when they don't know, and we'd be more likely to get them here than to invite them to go by themselves to a meeting. They like to do it in groups.
Okay, and you know what, since the parish retired teachers are gonna have a meeting next month,
Yes.
maybe that could be asked of them, and then if there's a consensus there, then I'll call Mona and we can set something up.
Yeah, that's fine.
Is that okay?
They can't go over there to that meeting?
Well, no, you're welcome to go to any meeting.
No, but that meeting.
Oh, the retired teacher, we're not gonna, all we're gonna tell them is that we wanna find out if they wanna come or have a meeting like here. That's all we're gonna ask them. We're not gonna say, we have to find out what the consensus is of the larger group. We have normally about 100 people there, so if we can kind of get a consensus of 100 people,
Yeah.
know exactly which direction to go.
The thing is, if they come to our meeting, we already have our guest speaker lined up, and if they start asking questions, we won't eat lunch.
Okay, I think there was another question in the back, please.
Just wanted to clarify.
We want you to use the mic, not because you don't have a teacher voice, but because it'll be dead silence on the video. It won't get recorded.
That's a good explanation. Just want to clarify for my parents. If they're on Medicare now and have the Blue Cross supplement, that is still going to be an option. And they could look at Humana.
Yes.
Sure.
Dawn, they can add and go back to, they could change the Advantage plan, but only between October 15th and December 7th, right? That's the open enrollment
Open
period.
enrollment.
So
We
you've
have
got
the
a
open
limited time when you can change
For the next year.
for next year.
Yeah.
Let me let Aaron field this. Oh, okay, you go over there. I'm coming over here with my plate. Let me go.
No, the date that somebody just mentioned is actually the open enrollment period for individual policies that are sold throughout the state. But this is a group plan. So it is up to the school board office to allow, you can open up your date for switching back and forth as per your terms. You don't have to follow individual policies. And I mean, like the gold plan, which has been mentioned.
Typically, open enrollment is going to happen a few months before the first of the year every year. So what you're saying and what you're asking is you can actually pick whatever plan each year at open enrollment. So you might want to be in Humana this year, and then if your doctor retires and moves out of town, you always have the ability to move back into the Blue plan.
Are there any changes to the current Blue Cross supplement if you're on Medicare and then Blue Cross?
If you're on Medicare from a primary basis and plan secondary, no, ma'am.
Not that this is a big dramatic thing, but it says no pay, no copay. Where are you getting the money? Who's paying for it? Humana's gonna just.
No, I'll tell you who's paying for
Wild
it.
hair?
Because they're paying the premium to
So
Humana.
that's cheaper? If they're gonna pay for it? They're paying for it now, so what's the difference?
The difference is we're paying the premium now and we're
Are
paying
you?
the claims. The claims, when you move to Humana, that's our advantage too, is to transfer our risk to another party that pays the claims.
Okay, going once, going twice, we're going to move on to the next agenda, okay? And that is to reconsider excluding Walgreens and Rite Aid from our pharmacy network. At one of the meetings and whatnot, it was brought up, and there was basically a consensus that we would delete Walgreens and Rite Aid because of a cost savings of $184,000. We have quite a few people who have spoke up and said that, maybe we should keep it at $184,000 is not really that much when you're looking at maybe a $50 million budget. We were asked to bring it up again tonight and whatnot, and what we'll do, there's several surveys that went out. Now, they're not official surveys. I have a group that I send to about 84 retirees, and I had a response of about 25 out of that. And what it came out to was 18 people said, yes, go ahead and delete them because of the cost, okay? And then 8 people said, no, keep them because of one thing or another. I had like 4 people say they were kind of in a yes and no situation because they really didn't use that particular drug store, okay? They were using their local pharmacies, Scott Pharmacy, Cannon Crow Pharmacy, et cetera, et cetera, et cetera. So they were kind of up in the air, but then out of that, they said but, and the 2 buts went both ways. So I split those 2 into 2 yeses and 2 nos. So that's where my little unofficial survey came out. Now, LP...
Can I question you? I mean, we didn't discuss doing a survey, and if we had agreed to do a survey with retirees, we would have had a larger audience at our next retiree meeting. We didn't discuss it, so, you're throwing me right now.
It kind of went into it this way, but we're just bringing it up because we were asked to do that, okay? And maybe, and I've discussed it with a couple of people, and when we did that, the school was out. There were no really active people in the sense of numbers that we could have gotten. Now that school is on and the teachers are there, I had talked to Mona about maybe trying to get something done where we could actually send a survey out to the schools as well as to the retirees and get a true feeling, because insurance is one of those things that affects everyone, and we're having 8, 9 people discussing some stuff and just deciding for all of those people, and that's some input from different people telling me the different things. So that's what we need to discuss for tonight. Yeah. Ma'am.
I'd like to make a motion so then we can have discussion, and my motion is to add back Walgreens and Rite Aid, if there's a second to that motion, so we can have discussion.
Okay.
Second.
Okay, it's been moved and second to put it back on the agenda, or to reconsider it? Okay.
To reconsider.
Okay, to reconsider. All those in favor of...
Public comment, please, sir.
What?
I have a comment on the vote.
Comment, okay, I'm sorry.
Give the
man a mic.
I'm just a resident of Lafayette Parish tonight. I would presume that in May, when you guys voted to remove Walgreens and Rite Aid from the prescription providers, that CVS was less expensive. Certainly, this is why we did that. We didn't keep the more expensive option, right? Is there a possibility that maybe we should approach Walgreens and Rite Aid prior to adding them back and try to renegotiate a better price than the $184,000 we were paying? I mean, maybe they...
Well, the problem, Justin, is your direction to us was to cut $450,000.
Yes, ma'am.
If we cut some of the 3 things that Mr. Fontaine discussed at the last meeting that he said would not detrimentally impact any plan members, if we cut those 3 and add back in Walgreens and Rite Aid, we're still within the $450,000 we wanted cut. And the discussion at the last meeting was that there were multiple CVS's open 24 hours, which is true. There's one CVS pharmacy opened in this whole parish, and it's in River Ranch. If you've got a small child, sick elderly husband, you live in Karen Crow, it's hard at 10 o'clock at night to fill a medication. So we called, there are 4 Walgreens that are open, 2 in Lafayette, Kelly Saloon in Johnston. There's one in New Iberia and one in Opelousas, all with 24-hour pharmacy. So the $180,000 is a lot of money, but it's also within, we can add it back and still be within your $450,000.
I'm totally with you on that. I makes me no difference how you guys get to $450. If this works best for you guys, I think that's great. My point was, instead of just blanket adding them back, perhaps just ask them, hey,
Can't hurt.
can't hurt to ask, right? That was my only point.
I think you make a very good point, and I think no matter how you get there, right? And convenience is important. I just don't think, I guess I just want Lynn to be careful so that we don't encourage bad behavior. We already know we're overpaying for the same drug at a different place, and it's not right to anyone. You are the taxpayer to say, well, we're going to buy this from you and we're going to pay higher and we're going to do it because you have 4 24-hour locations. Let's let them know that we mean business. We want them to be competitive with CVS and others. We want to do business with them, but they need to be competitive.
I'm going to give you a little clarification on some of these things. Excuse me. If there were a certain set of medical providers on the medical side, not on the prescription drug side, that we could go to and garner deeper discounts, you can do that on the medical side. Your pharmacy discounts are all embedded in your prescription drug plan through your pharmacy benefit manager. And the new pharmacy benefit manager that we utilized last year, they're basically, some of them are going to have better pricing arranged through a CVS versus a Walgreens. Other ones are going to have better pricing arranged through a Walgreens versus a CVS. So it's not a situation where we can go to those local chain drugstores and negotiate a better deal, because that all comes through your pharmacy benefit manager's contract that they have basically on a regional or national basis. So, for example, if your pharmacy benefit manager was Express Scripts, who is more aligned with Walgreens, they would be giving us a savings figure to move CVS out. Okay? So that's how that works. So that's not that feasible. It's basically they cut a better deal when they narrow the network and align themselves with a partner on one side of the fence or the other.
Question in the back.
Who picks the pharmacy provider, or the person that is more favorable to one than the other? Who picks that person?
When we look at these pharmacy benefit managers, we're looking at the aspects of discounts off of the cost of the medication. We're looking at the networks. We're looking at rebates available to the plan. So all of that's evaluated, and who's picked is who gives us the best deal.
Okay, so somebody has studied this and has gone to Walgreens, whatever. And
Remember when we moved from Blue Cross's pharmacy network to RX benefits
well, my only
this year?
question is, my only problem with that is, I mean, if, as she says, CVS pharmacies are closing all over, and maybe in that particular thing they had, that pharmacy provider or whatever was the best. But I mean, why? To me, the biggest thing you're concerned about is drugs, the cost of drugs. So you need to find whichever one will. I just don't understand why something is forced down your throat. If somebody in this place can get a cheaper price from Walgreens or whatever, that you have to take the plan of a pharmacy that's going to be closing and you can't use. That doesn't make much sense.
These savings, these are all savings alternatives that are available to us. They're all going to have pros and cons, okay? And there's a savings number to them. So, you know, one of the discussions that you're having is it worth $184,000 to narrow your network versus some of the other benefit alternatives that you have on the table.
But is it narrowing the network, or is it your prescription benefit? Because when we had Express Script, y'all had another prescription benefit manager. And you all had to go to Express Script. Then you revamp, and then you have RX benefit now. So then we had to all come back to Kim. So is it really, is the prescription manager that drives it? Am I saying that right?
It is a prescription manager that drives it. But in both Express Scripts are in the RX benefits, you could go to any drugstore you wanted. All of them are giving savings options for narrowed networks, okay? Just like we could look at a narrower network on the medical side. It would have a savings number. You have to weigh out the pain versus the gain.
I was just curious, if you eliminate CVS and you eliminate Walgreens and Rite Aid, how many pharmacies do your employees have to go and get their medications? Not? Just
It would, well, you would be eliminating a lot of it because those are your big box, national chains, and you would be left with more of your local providers, which there's several of them.
Yes, we
Yes, we
do.
do. Any other questions? Okay.
Okay, we've had the discussion. Do any of the committee members have any questions or comments?
I have a comment.
Give me the comment.
My perspective is the more choices we give people, that we can afford to give people, we should give our employees, active and retirees. If you remember, the administration had put back Walgreens and Rite Aid. And it was this committee that took it out because the belief at the time was that there were other 24-hour CVSs, and we found out that that was not the case. So to me, if we can give the board the $450,000 that they've asked for, without removing choices for drugstores from employees, that to me is the preferable option to go.
Here's a question that I have. In putting it back, would that increase our premiums, or taking it off, would it decrease our premiums? The premiums are set. Okay. Yeah, I know. Just wanted to make it clear. Okay? So basically, there's no change in premiums one way or the other. Okay? So with that in mind, I guess we'll call for the vote. No, we have a motion and we've seconded, yeah.
The motion on the floor is to return
it.
Walgreens and Rite Aid
Return
as
to,
an
yeah.
option.
And it's been seconded.
Question.
Yes.
Okay, if it's, where's the 450 coming from if you put that back in?
The three things that he had given to us.
So it's already there? So the savings is there, the cuts are there?
More than the 450.
We were presented with three items at one of the other meetings and whatnot, and basically it was going through coupons and a couple of other things. Mr. Fontaine, are you going to give that to us tonight, the 1, 2, and 3?
Yeah.
Okay,
do
all
that
right.
with
So
you, yes.
let's just wait just a little bit, and you'll hear from him, and we'll give you the numbers and whatnot, okay? Okay. All right, so there's a motion on, I'm sorry.
Are they comfortable voting on it before they hear the information? Apparently a lot of people are not sure where the savings are coming from.
Yeah, we need to, because we were there, we know what they are. Okay, so I need a show of hands, okay? If you agree that we return it, please raise your hand. I'll do the counting. Okay, 4. And opposed? 3. Okay, and I have to tell you, okay.
Oh, you didn't vote, I was on, okay, I was number 4.
Okay, I want to make sure.
Yeah, you got it.
I want to make sure. Okay, all right, so it's 4-3 that we put it back on, okay? All right.
Mr. Chairman, you have 8 members.
We have 1, 2, 3, 4, 5, 6, 7, 8. Okay.
You comment yourself?
No, I would break the tie, would I not?
Did you not vote?
No, I didn't vote.
Oh, okay, all right.
No.
I thought I saw you raise your hand.
I just want to make, no, I just want,
Yeah, you watching, demonstrating. We are watching.
what I was demonstrating.
All right,
Okay. All right, okay, all right. You know, it's the teacher. You know, you have to demonstrate to those children, okay? That's just what it is. Okay, so it's back on. Okay, any questions right now? That we can, if not, we can move on. All right, the next item is the prescription drug saving opportunities for the plan year 2018. So we'll get back to Mr. Fontaine, and he can give us the information that I think that some of you are requiring.
All right, so this is a review of the previous meetings. When asked to come back to board on the requested savings, I gave several different savings alternatives, and I'll go through those for you now. One of them, the narrowing of the network and Walgreens and Rite Aid was in the first phase of savings. So remember that if we're looking for 450,000, that it's actually, we're going to be looking at a little more because you're taking that number, that 184,000 out of the first group of savings. So given that, the first alternative on the second round of additional savings alternatives was coupon subrogation or specialty coupon management program. Brand name medications have coupons from the manufacturer. I don't know if anybody in the room's ever used one. Many of you probably have. If you have a high deductible health plan or ever had a high deductible health plan, or if you had a high out-of-pocket cost, manufacturers offer savings or coupon savings to the member to help them financially to be able to utilize that medication. This is not something that is for generic medications. This would be specifically for specialty medications. What are specialty medications? They are very high-cost meds. Specialty medications have come into the industry in the last 6-7 years. Many of these medications are several $1,000s a month in cost. Okay, you guys, our folks, have a copay structure on your prescription drugs where there's not much of a demand for a coupon to save money with because you're only paying the copay for that drug. So, for example, if that medication is a brand name medication and it costs $3,000, you're only paying a $30 copay and the plan's paying the rest. Okay? What this specialty coupon management program does is your specialty medications would be received through the specialty pharmacy. They would in turn get the coupon from the manufacturer and give us a savings. Doesn't affect your benefit, doesn't affect your choice of medications, just helps us with savings. The predicted or the projected savings on that coupon management, $350,000. So that does not have disruption or an impact to you. Okay. The second item was low clinical value to eliminate medications from our list of covered medications that have very low to no clinical value. There are certain medications that combine two different medications, let's say, that can be purchased over the counter at any drugstore. Okay? And on a brand name basis. Some of those medications are very, very expensive, and it eliminates those from the plan that have low to no clinical value. Okay? Very few prescriptions in this area. You can count them on your hands, but they are very expensive when we allow that to go on to the plan. It's not giving anybody a clinical value, it's giving a value of convenience. So instead of going to the drugstore and purchasing an over-the-counter medication, we'll allow a brand name medication to be prescribed and pay hundreds of dollars or even thousands of dollars more for that medication. So very little impact. The savings were $167,000 on that one. The next is a high dollar prescription claims review, $322,000 of savings. This is to put tighter management of these high-cost medications in that we see are being prescribed on a more frequent basis, some of them being specialty medications, some of them being high-cost brand-name medications. Very little impact here as well. Just to make certain that if we're going to pay for a high-cost medication, that's medically necessary, okay? And that lower-cost alternatives have been tried and all of that type of thing. If we don't do that, we're going to see our prescription drug costs continue to increase. These specialty medications that I alluded to that weren't around in the marketplace several years ago are predicted to be as much as 50% of our total prescription drug claims in the next couple of years, and by 2020, prescription drugs could be as much as 50% of our total claims costs. Part of that's good, okay? There's a lot of generic medications out there and low-cost medications, let's say in the cholesterol or high blood pressure diagnosis that keeping people off of an operating table. Obviously, that's cost-effective, okay? But many of these specialty meds can cost $7,000 to $10,000 a month, and we want to make certain that they're available to our membership, but prescribed when medically necessary. Okay? Some of those big indications of those medications are for rheumatoid arthritis, Crohn's disease, new ones out for plaque psoriasis, things like that. We want to make certain that when that medication is prescribed and the plan pays for it, that lower cost alternatives have been considered and tried. It's prior authorizations where the prescribing doctor is talking to pharmacists and physicians on the prescription management side. Mm-hmm.
So no one will be denied a medication that they need if this is approved?
Correct. You're right on target. So these first three with $350,000 of savings, $167,000 and $322,000, very little impact there as far as benefits to the plan. The next one is the Advanced Control Drug Option Formulary. So,
Can you please vote on those three before we go to the formulary?
Yeah, the thing is, Lynn, we separated the formulary into a separate agenda item.
Okay.
So you're rolling into the next one. She wants to dispense with this one.
I make a motion that we approve those three cost options that will not detrimentally affect the plan members.
Okay, we have a motion to approve the three items mentioned for the cost savings for the insurance plan. Do I have a second?
Second.
Okay, we have a second. Okay, all those in favor say aye.
They may have some comments.
Oh, do we have any comments? I'm sorry, I'm moving kind of fast.
I just want the comment that Ms. Mouse made, that we get in writing that you will not be denied your drugs.
Okay, all right, so we have a motion on the floor, and.
before
Yes,
you make that, Anybody can be denied a drug based on a prior authorization presently. Okay, doctor, there's medications in your current plan that require prior authorization.
Right.
That doctor can call and ask for prior authorization and be denied. Okay, so I mean, just because a medication is in your formulary doesn't mean that a doctor can just automatically prescribe it. So, for example, if you go into the doctor and complain of something orthopedic, it does not mean that he's going to be able to prescribe a $10,000 a month med right off the bat.
Yeah, he'll have you try other things before.
Right. Correct. Just so we have understanding on that.
Okay, we have the motion on the floor, it's been seconded and whatnot. All those in favor say aye. Aye. Opposed? Motion passes. Okay, that takes care of that particular one. The next part of this would be basically on the formulary, the number 4 that we had seen in the past from the formulary drugs, the pricing and whatnot. So if you could give us the presentation. And this basically, as I understand, this is an information item for us so that we can digest it and then we'll come back and we'll vote for it or against it. Okay?
So formulary is the easiest way to define that. That's the list of drugs that are covered under your plan. You currently have an open formulary that is very, very broad with regard to the drugs that are covered under your plan. Basically, this is a tightening of that formulary, closing it, and taking some of those medications off of the plan. When you do that, obviously there is going to be some minimal disruption. The disruption when RX Benefits did the analysis was 3 to 5%. Remember that when we take a look at the prescription drug utilization in the plan, around 85% of the medications that are utilized in the plan are generic medications. Okay, so this is more concerned with some of the brand name medications, that type of thing. So it would affect about 3 to 5% of those meds. And the reason I say 3 to 5 is that's going to vary with utilization from day to day, month to month, year to year. For example, Blue Cross, United Healthcare, many of the carriers are moving to close formularies and giving no choice on their fully insured plans. So if I'm working for ABC Incorporated and we're insured by Blue Cross of Louisiana, my formulary is getting tightened on me. Folks, as far as prescription drugs go, this is an area that has an annual increase running anywhere from about 12 to 15% a year. If we don't become proactive in controlling the prescription drug costs, we're going to have to be reactive. And when we are reactive, that means that we're dealing with playing catch up. So, tightening a formulary is where the industry is going. But I want to let you know one thing. When a formulary is tightened, it does not put any member in a situation where there is not a large choice of medications to treat you with. It's taking the ones out that are the least cost effective or don't have the best clinical effects in that plan. Okay? So it's never going to put anybody in a situation where there's not a choice of medications for the doctor to prescribe. It's tightening the list, and most of it's based upon cost and the efficiency of that medication. Okay? So that's the explanation of it. Now, obviously, the first three have little to no impact. This is going to have some impact. But remember, 97%, or let's say 95 to 97% of the plan's membership Not going to feel any effect of this, okay?
Example of the drug you're talking about. Trying to understand.
I don't have, I can't, cause it's gonna be some of these rare, high dollar, meds that have very infrequent use, but might have a category where there's, 10 medications that have an average cost of, let's say, $2,000 a month, and this one's $6,000 a month.
What I'm trying to think. If I have gone in my physician, thank God it's not me, I've been in my physician, he has tried multiple medication, generic, multiple medication, to treat whatever the illness or symptoms I have. So we finally have a medication that's working. So now you're going to tell me I may have to lose that medication because of this formulary?
That could be a
Provide everything
possibility, but that, I've seen this, other groups implement this. Those situations will come up very, very rarely, and when those situations do come up, that they're considered on an individual basis, and in some, if there's agreement from a medical director's standpoint, there's an override done on that.
As long as there's that override.
And who does the override? Is that local?
Medical director and.
Is that, what do you mean?
Our overrides now for some pharmaceuticals is an appeal to the insurance department locally. Will this override be done locally, or will it have to go through the people in Alabama or whoever it goes through?
It can be done locally, but then has to be approved by the PBM as well.
This does, that's what it's
A
trying.
a dual effort.
You say 3 to 5% of the.
Remember, you're a partially self-funded plan. You know, if these folks say to pay it, it's going to be paid.
So when you say 3 to 5% of the plan members could be affected, is that 3 to 5% of the 10,000 lives we cover? Because that's a lot of people. Or is it 3 to 5% of the people who
Use the plan.
are using the plan, or I mean, as in employees and retirees?
3 to 5% of the folks using the plan, so very small population of people.
Unless you're one of those who can't get the medicine.
Right. In that event too, if you know, if there is supporting evidence and real documentation that everything else in the formulary has been tried and not worked, I don't believe that would be a situation that would, you know, preclude somebody from taking a medication that's going to keep them well. I can count on my hands in 34 years times that's happened.
This is an information item. Does anybody have any questions before we move on?
I have a question, just for
Okay.
everybody's here. Before this is voted on, there would be another insurance committee meeting.
We're going to have another
Everybody
insurance
would
committee
know.
meeting. Yes, ma'am.
Just to be clear, you're saying that if nothing is done, those costs will continue to rise at 12% or higher over the next year, next couple of years. So it's something that needs to be addressed regardless.
So we all hear talk about healthcare every time we turn on the news or anything like this. So you have healthcare statistics that we call trend. It's the inflationary trend of healthcare. On the medical side, that's flattened out a lot in the last several years and is running anywhere from 5 to 6%. Okay? Now, on the prescription drug side, every time we turn around, there's a new specialty med hitting the marketplace. There are medications out there now to put people in remission from hepatitis C. That is cost effective. Okay, they might be $35,000, $40,000 a month, but you take them for 3 months, And I would certainly rather see this plan pay that than pay for a liver transplant or kidney transplant. Cost effective, okay? But if we don't take proactive measures to flatten this 12 to 15% curve, and we don't do things proactive that are smart, and we allow the plan to pay for the $6,000 drug when it could have had that doctor look at the choices of the $2,000 and $3,000 drugs and easily prescribe one, we're going to wind up in a financial bind. You know, a lot of us don't realize that this is a $40 million health plan. Okay? You guys are paying a small portion of it. These folks, it's a $40 million health plan. That prescription drugs is the highest rising cost component. So an ounce of prevention certainly is a wise choice. Now, you have other savings alternatives on the table, and I know we have a financial goal to get to, but when considering all of this, if you have something on the table that you know is going to curtail unnecessary costs to the plan, and you're a member of this plan, okay, I'd be protective of it, because the benefit that you enjoy and the cost that you pay for it, okay, when you talk to your neighbor, okay, and that neighbor works in the private sector, they don't have what you have, okay? They don't have a plan on that basically has no cost to you on the medical side with a $90 a month premium, or a Medicare Advantage choice with no premium and 100% benefit, okay?
On the other hand, going back to St. Tammany and Ascension, their premium cost is less than ours, and they gain almost better benefits or similar benefits.
Let me,
So what's the difference?
you know, I had heard that, and I'm gonna answer you this way. All the large employers that are self-funded are embracing and making all these choices at the same time. So if you looked at St. Tammany's 2016 benefits, all of the things that I'm talking to you guys about, they are considering and voting on as well. Okay, so if you look at St. Tammany's portal or website, and you pull their current benefits off of it, they're going up on their copays. They're going up on their out-of-pockets. They're instituting copay subrogation, tighter formularies. So here's your best example to address that. Blue Cross as a whole, okay? The majority of most employers are not self-funded because they're not large enough to be, okay? Most situations, an employer is going to pay an insurance carrier premium, and they're going to provide the benefits, okay? Blue Cross statewide is implementing these types of things because their prescription drug costs are getting out of control. So they're all measures that when you look at all of the larger school systems, large employers, that they're looking at all of these measures on the table and implementing them because they're dealing with the exact same thing. When they look at their health care costs, their medical's pretty flat, their prescription drugs are going through the roof. Because every time somebody is prescribed a Humira or an Enbrel, that's another $7,000, $8,000, $9,000 a month that this plan's going to pay for that particular person month after month after month. So we want to make certain that when that person fills that script, that it's proper, it's medically necessary. We still have plenty of choice, but if there's one out there that's just outrageously expensive in that category, do we need to still include that?
So are you saying they're managing their plan better than we are? That's why their cost is so much less? What are you saying? I'm asking.
When you look at cost, what you're looking at is how much they charge the employee. I think that when you look at true cost, is you're not seeing what they pay.
Board pays.
Okay.
Board
You're only seeing the employee share of
We have
it.
a lot more money than we
Pays more.
use.
So you're saying that? Are you saying the board pays more for the employees?
But he did not say that.
No,
honestly.
it's a different set of benefits and it's a different population. It could,
Full plan, so is their board paying more than we are?
you can't compare your plan to another school district because it could be demographically different. You could have a larger number of employees per capita. The cost in one portion of the state can be higher than the other. All of these factors have to be considered. So you want to make sure you're at market when comparing to others, and you are, okay? But you really can't say that the claim should be equal because it depends on demographics, what set of doctors and hospitals they're utilizing, all of those factors come into play.
Thank you.
Yes, ma'am.
I'm just a little bit concerned about the use of the word benefit. There are an awful lot of retired teachers in the, and I know it's a benefit. I know that, but it was a benefit because so many people stayed in the public school system, and particularly Lafayette Parish, because of the insurance. And that was part of the deal to get people to come to this parish and work. And so it's almost like we're being criticized because we think we ought to have this benefit. And it's just the use of the word. And I think if we come at it with an approach that all these people in this room worked for this, and they worked very hard. So I just would like for us to be real careful.
In the way I've addressed that is I don't know that you could have an employer that agrees with you more when what you're offered is pretty much 100% coverage on the medical side and co-pays on the prescription drug side. And when we talk about the structure of those benefits, nobody has said, hey, Lynn, gut these benefits because we need to save some money. The emphasis here with all of these benefit alternatives has been what affects our employees and retirees the least and saves us the most money. That has been what I've been charged with, to bring savings alternatives to the membership of the plan and the board, but that have the least impact on your pocketbook. So a lot of these alternatives don't change your structure of your benefits at all, but do provide us some savings. So I think that from what I see here in your structure of your benefit plans, the Lafayette Parish School Board probably is right in sync with that same line of thought.
As most of the people in this room at some time or other have served on an insurance committee or worked some way to make this happen, so that they would have.
I appreciate the way you've spoken tonight, because I have a much better understanding, and I appreciate that. And I think that's part of the problem. I don't know how we can do a better job of letting all employees understand this. Question one, the formulary changes and everything, will that affect active and retirees?
Yes, ma'am.
Okay, I think we need to a better job of telling our people that we who are members of organizations are trying, but we're not hitting everybody. The way you just said about that formulary, narrowing it down with the least amount of pain for anybody, has to be spelled out to the employees. I don't know how else to say that, but that's part of the confusion.
Agreed. I will tell you, it's not an easy job because you're talking you're talking about things that people just don't know about or understand, and it scares them. Mhm. So it takes careful consideration, and we're going to, once we come to the decision on this, we'll make sure that the education portion of it's there.
Why was this an information item and not of something we were going to vote on tonight?
Because we didn't have the formularies. Okay, there was nothing that was presented until tonight. We weren't too sure what was, and we didn't even know if we was going to be able to get it. Okay, so that was another situation.
We still don't have it.
Okay?
I think one thing you might be confused a bit with, Mr. Butchers, we were talking about formulary analysis on the
Right.
Medicare Advantage plans, but that's not what we're considering here.
Well, no. Yeah. Things have changed.
Do you have the formulary?
What's that?
We do have exactly what this is? The formulary, what's being
Yes.
changed?
We'll get that distributed, yes, ma'am.
Okay. I think that. Yes, ma'am.
To follow up on what was said, which I think was an excellent point. Mona, can you look at finding some ways that we can put actives through a PACE call, and with retirees, email or mail? I know mail's expensive, but maybe somehow, because we have a teachers organization that's got 100 people, and we've got thousands of retirees. If we're going to change prescription drugs that people are taking, I think she's exactly right. We have to find a way to communicate that to everybody before it happens to them. And they go to the doctor or they go to fill a drug and the pharmacist says, oops, you have to go back to your doctor.
We would won't we be sending communication out through RX benefits to people affected?
Correct. One of the things that we've gained in utilizing our third-party pharmacy benefit manager, RX Benefits, is any of these changes, when implemented, not only do they provide good communication to the group on a global basis, but any member of the plan affected by any of these changes is contacted on an individual basis and transitioned through before the change is made.
Not before the change is made. My question is there any way to get all that information out before this committee were to vote? So if someone had concerns, they could come to that meeting when it was decided.
When we meet
Yes,
again,
ma'am.
if we draft a notice, we can email it to Dr. Aguilar. He'll do his revision, make sure we don't have anything out of whack. He can send that via email to all of the other items.
So how do we get it
Then
to all
all
the
we do is
retirees?
Yeah, that's another. How
It's
we
not
address
just
that?
well,
And some of them
all
don't do email.
I can get it to all the members of the organization, but that's not all.
It's a small
No.
minority.
And a lot of them don't do emails, y'all. You have to mail.
I do, and I could probably, it's thousands. So, and it takes us days to get that out. So it depends on when y'all going to make. I can send a post. And I don't have all their email addresses. I have just street addresses. But I mean, we'll get it out the best we can.
I think we could also get some help from RX Benefits on that. I mean, they've got their addresses and things like that, and they're going to
Even
be...
if it's just a postcard, because that's a cheaper way that we often will invite them to a meeting or whatever. Yeah.
I didn't know.
Yeah. Yeah.
Great. Okay, any final questions for Mr. Fontaine? Yes, sir.
Going back to the Walgreens thing, all I'm pleased with.
We need the mic.
Although I'm very pleased that Walgreens would be added because that's the one I've used for years and years. And we talked about negotiating with them. What assurances can we have that a negotiation has been tried with them? Because, I mean, I know it's certainly something that's, done in a completely different manner, but I still think, though, that, because I know I mentioned it to the pharmacist at Walgreens, and he was pretty much in a panic because this is, a large portion of employees here use Walgreens. So I certainly think that if they know that some type of negotiation can be done, and it would be a saving of probably more than we expect.
The negotiations are something that is the not sole purpose, but it's the main purpose of having a pharmacy benefit manager. That's what they do. They are negotiating prices from the manufacturers, the drug manufacturers. They're negotiating with the pharmacy on dispensing fees, all of these types of things. So what assurances, if you have a third-party benefit manager, and as your consultant, that was one of the first things we looked at. I think the first time I reported to you guys, one of the things that we pointed out was the high-cost prescriptions and came up with solutions. So that was one of the first things we did. Went out and looked at larger discounts, larger rebates, all of that type of thing. So that's a process that's ongoing and happens all of the time.
Can't hear a word.
I'm sorry. I'll start from scratch. Let me see if I can remember everything I said.
Pick up.
Your pharmacy benefit manager, one of their purposes, and one of their main purposes, is to negotiate with the drug manufacturers and to get us the best pricing on those medications, to negotiate with the pharmacies, to negotiate dispensing fees, rebates from the manufacturers. All of those things are being done constantly. RX Benefits actually does this with the three major pharmacy benefit managers, Express Scripts, Optum, and CVS. So this is an ongoing process that happens daily, monthly, and annually. So that's constantly being done. So we're always going to be looking at where we can get the most bang for the buck on the pharmacy side of things. As far as individual Walgreens and Lafayette, we as a partially self-funded group utilizing this pharmacy benefit manager can't go down the street and basically cut a deal with just the Walgreens in this area. If you remember a few years back, every person that had Blue Cross on a fully insured basis, Blue Cross uses Express Scripts, and Express Scripts and Walgreens kind of went to war and over their contract, and all of a sudden you had probably 60% of the people in the state of Louisiana weren't going to Walgreens for a while. So those things happen.
Okay, it's kind of like a supper time, kind of. We have one more thing to do. If anybody has any questions, we'll thank Mr. Fontaine for, yes.
Just want to ask, when we do this mail out, we're inviting, are y'all going to set a meeting where we invite the retirees to come? Okay, just
Yeah,
check.
we can do that.
I thought it was an informational.
Or you just want to send an information piece, what's being considered?
Yeah, the information piece.
Okay.
Because they're going to get more information
Yeah.
from.
Got it.
As we get
Yeah.
more, yeah.
And you can include the date of the meeting, too.
Yes, yes. And so, Mr. Fontaine, thank you so much for coming down and making that trip all the way from Houma. We definitely appreciate it, and we're glad that you had sunshine all the way.
It's not a long drive, and I'm glad to be here.
Fantastic. Okay, the last thing that we were talking about, and I asked Mona to put this on. Okay, and also, at the same time, I asked her to get the rules of governance that we had done a couple of years ago. One of the things on it was basically that at the first meeting of every year, every new year, we would vote for a chairperson and vice chair and whatnot. Well, we haven't done that, in quite a while.
What, 3 superintendents now?
I think 3 superintendents,
3
right.
superintendents.
So Lisette and I have had the honor of doing that and whatnot. But we need to kind of talk about that and see if we can't move into maybe a direction that maybe someone else would want to take charge, et cetera. Also, and then we need to set frequency dates and whatnot, that we really, this thing is coming whenever we want. It's not really cool. So we're looking at, we're going to have to get together at another meeting where we will come up and attack the governance that we have already, okay? And so for just your information, we'll, on the next meeting, I think what we'll do is we'll have that as part of our meeting to fix, adjust, because what we've had also is that we've had two people who are on the committee who have retired. And we thank Vicki So for taking over for one. And so it's a situation where we thank you very much. And if there's anything that we'll do, we'll try to get things done.
We also have positions that are vacant.
Yeah.
So if you all know anyone who might want to serve, active teachers, I think LPAE needs another representative. Is that right?
No, ma'am.
No, not
Oh, at large.
At
A
large.
teacher at
At
large. So
large.
any active teacher who might want to be on the committee, and we have transportation vacant.
She just has, is that vacant or does she have time?
She's not here. Clyde's with the crafts and trades. Now,
He's not
but now Giselle has retired.
And so is
we would need,
paraprofessional.
and who?
Paraprofessional.
And the
Patsy.
paraprofessional. We have two of them. Yeah,
I
two.
do have one bus driver who's expressed an interest.
Oh, really?
Because I was going to J-call out Monday to the Paris and to
Fantastic.
drivers. I don't know how long you want to leave it open, maybe till the next meeting for nominations.
Well, I'm thinking we probably should have a next meeting within the next 2 weeks.
Yes, if we want to get, we really need to get these items, your recommendations to the board by like their September meeting, 13th, and my agenda has to post on the 8th. So
Okay,
between
then-
now and the 7th.
Okay, between now and the 7th. Okay. Let me kind of get and see how
Okay.
their schedules are. I don't think anybody's taking vacation, so we'll be cool. Oh. Wait, there's the 4th. That's coming up.
I can't do the last Wednesday of August because
Okay.
of the training.
I need a motion to adjourn.
So moved.
And seconded, and meetings adjourned. Thank you, ladies and gentlemen.